All right, got another case for you today. Jose Almeida coming to you for our IBC community. Last Friday at the hospital, at Jackson Memorial Hospital, did a patient. He's been with us for a while. I'll show you his history. 60-year-old guy, not very compliant. Originally presented with a vena cava filter that occluded the vena cava and bilateral iliac veins. That was about 10 years ago. The filter had been in for 10 years, and I'll show you what we did 10 years ago, removed the filter, and we're able to recanalize them and line them with stents. We had some extravasation from the filter removal, which was always stable. I'll show you that because that can happen with these things. And then 10 years later, we've, I think, relined him with stents once in the last 10 years. He's occluded a couple of times since 10 years ago till now, probably from just non-compliant with his anticoagulation. So today or the other day, he came in with bilateral stent occlusions with symptoms. And we attempted to reopen both stents last Friday. And I'll show you what we did. So let me share the screen here. Hopefully you can see that. So this is him originally with the typical caval occlusion, venous collaterals on the abdomen pattern. This was his filter. As we often see, filter tines into the aorta and the lumbar spine. There you see complete penetration of the cava into the aorta. A nasty looking filter. Typical from above this sheath, a bird's beak occlusion of vena cava. There's the filter and bilateral iliac vein occlusion. We were able to snare it, and from the internal jugular vein sheath, the old grip it and rip it. And nowadays we have a nicer laser to help us remove these things, but then it was just what would I call gentle brute force. When the filter came out, venography showed some local extravasation, always hemodynamically stable. We see this, or we saw this often when we did these in the past, with chronically occluded vena cavas with the retroperitoneum overlaying them and perivenous fibrosis of the vena cava. One can get pretty aggressive removing these things, everything tamponades locally because of the coverings and the perivenous fibrosis. So you can get away with a little brute force in cases like that. Sure, you got to be careful. You can see from below with the Triforce catheters, we were able to cross the iliac vein occlusions. And here's the right venogram, occlusion above, left venogram, occlusion above, and Triforce catheter recanalizing, and bilateral balloon angioplasty, kissing balloons, and bilateral iliac vein stents were placed with pretty good flow. So that gets us to today, where, let me find this for you. I thought I had it all set up. All right, so last week, here we are, bilateral iliac vein stents. You can see the relining. Let me show you this one. So this is the problem pre-RevCore device. We relined the old stent with a new stent. You can see that the new stent doesn't fully deploy against the old stent because we could only recanalize the thrombus, do hyperinflation of the balloon, and push everything to the old stent wall. So when we relined, we lose lumen every time. So you can only do that twice, maybe 3 times, and then you lost all your lumen and you have to give up and depend on collaterals. With the new RevCore device, we can actually scrape out the old thrombus so that if you do have to reline it, and hopefully you don't, it'll be on stent, so more preservation of lumen. So let's see, what are we showing you here? This is the common femoral artery, occluded femoral vein below, completely occluded on the left with pretty much no inflow. That's compressing the artery, trying to find a vein, and eventually, so I stuck an occluded femoral vein. It's me navigating the needle to behind the artery and was able to get in the occluded vein. And usually we can find a little channel of flow, able to thread a wire. We use this fluoro to guide us. So it's a combination of ultrasound and fluoro. There I am radiating my hand and navigating the wire up. So we did get some channel at around the mid-thigh of the femoral vein. Go ahead and upsize to a micro sheath and do a venogram. So here's where our access is, and I don't have much room to exchange for a bigger catheter to do a more aggressive recan from here. So I thought going from below might be better at the posterior tibial vein at this point. There's our venogram, a lot of collaterals, the stent secluded. These are collaterals around the stent, an occlusion of the femoral vein with the collateral going around it. You can see that occlusion of the femoral vein with a collateral going around it. All right, the femoral vein down here, the lower thigh is open. Now, what are we doing here? Going to get access from above. This was strange that the carotid artery was over here and the vein was lateral. The internal jugular vein was very lateral. So that was unusual. So we had to be careful. Here's the wire coming down. You see how lateral it is as it gets into the right atrium. We always do that with fluoroscopic guidance. We get a Benson wire down, and now a venogram shows occlusion of the, this is actually the left-sided stent over here and the right-side stent over here. They crisscross. So now we're using a dilator to create a tract from above because we're going to put the big protrusive sheath down the inferior vena cava. The protrusive is the funnel for embolic protection while we do the rev core on the left. So here you see under fluoro, the big sheath coming down, again with a strange angle, a little more lateral than we like, but we knew we were in the inferior vena cava. We confirmed it with IVC and venography. Very important. You don't want to put that big thing in the carotid artery. And believe me, people have done it. Here's the big protrusive sheath coming in, and it comes in from above, and here it is coming down, again under fluoroscopic guidance. Always need a straight wire in front of you to do it safely. As you get through the heart, you need a straight wire. That's the other wire from below on the right side. And here's the funnel being deployed right here, wire mesh basket. So this is the protrusive sheath from above in the jugular vein. These are bilateral stents. We are up one with IVC, and we're looking at the funnel with IVC as it was deployed. So where are we at this point? We were able to cross the right side easily. The right side wasn't even really completely occluded. A lot of stenoses. The wire went up easily with IVC here. Just look at this area. You'll see that multiple other areas of narrowing, like here. And as we go up and down, you see the catheter going up and down the right side, the IVC catheter. You see how narrow the stent is from being relined, but it's open there, very tight here. All right, and in the Hesperia, we did a balloon angioplasty and then completion IVC. Things are looking better and more open. So that looks a lot better after balloon angioplasty on the right, and contrast venography showed pretty good flow. So back to the left side, which again is occluded. Here's our catheter from below. And what I'm showing you here is direct puncture of the distal stent with a needle under fluoro, and how I just navigate the needle under fluoro, radiating my hands at the same time. And here I got a cross lead wire into the stent and navigating the wire north. These wires are great for crossing occluded stents. Here we'd use oblique views to ensure that the wire is inside of the stent. Of course, you can confirm that with IVC. So we're happy with that. Now we just want to get through and through access with our wire. So from below, we're going to feed this all the way up through the funnel to the jugular vein and retrieve it up top. So now that we have through and through access with the wire, you see the wire up here, which makes things easier for tracking devices up and down like the rev core. Here we are prepping the rev core, and we're going to come down from above. The plan was to come down from above, go through the stent, thrombectomize it with the rev core, and hopefully be able to get into the distal stent at the level of the groin and actually get the device into the native occluded common femoral vein. That was the idea. And then from below, where we access from the tibial vein, kind of connect a tract from above and below, working above and below, and recanalize that occluded common femoral vein. So that's what we're trying to do here. Here you see the rev core coming down the protrusive, and it's on the wire to the left-sided stent. Here you see the rev core coming down the occluded stent over the wire that we had placed. Again, the wire enters here, so I wanted to hopefully get this thing down in here, get a new tract, and from below the wire up and connect the dots. That's what we were trying to do, but we were having a hard time. This is from the posterior tibial vein access, a Triforce catheter coming up, trying to wire and cross this area that was completely occluded. Again, so working from above with a rev core and below, try to get this segment open. And you spend some time, there's a lot of friction in the system. It just wasn't going great. So at the end, we just decided to stop and maybe come back another day. So one option is we tried sharp wires from below to try and cross this. They would not cross. Maybe come back another day with the RF wire from Bayless, and probably would be safe if we get things lined up well. The wire should be able to get through here. Of course, taking care not to injure the artery or the nerve. You got to be very careful. It's a little long for me. When I use sharp devices, I'd rather cross a couple of centimeters. It's just a little long. That's why we didn't have the Bayless there that day. So I just stopped. I didn't want to get too aggressive with sharp devices at that point. We got the right side open and flowing, and that's usually enough, at least that the vena cava is open, at least get rid of the fatigue. All right, so that's the case from this week. What are the lessons? Well, we did get one side open with balloon angioplasty. So really, if one side is open and you've got return of the vena cava, they have preload and they do okay. When the vena cava is completely occluded, they really get a lot of fatigue because they've lost the preload of the heart. And then often when the side is open, you will get some cross pelvic filling and the opposite leg, in this case, the left leg with the occluded stent, sometimes that'll improve just by having the right side open. So we're going to give that a chance for a little while, but if he's still miserable on the left side where the occlusion is, maybe we'll come back and be more aggressive with something like the Bayless wire and try and cross the common femoral vein. I personally don't like endovenectomy, the open procedure. It's usually a long, deep groin dissection. The dissection is extensive, a lot of bleeding, a lot of complications afterwards with lymphoceles, hematomas, infections. They have to be in the hospital a long time, and they ultimately go on to occlude anyway. So I've did those in the past and have been pretty discouraged overall, so I don't do those. So I'd rather try and cross it if we can, and if not, just leave it occluded and let him live off his collaterals. The beautiful thing about venous surgery, you're not going to lose your leg from venous occlusions. Have some swelling, may be miserable with the leg, but you'll keep your leg, unlike arterial occlusions. So that's it for now. Jose Almeida signing off here in Miami Vein Center in Miami for IVC Community. Thanks.